All right. Welcome everyone to our CDIM webinar in November. And this webinar is pretty special because it's the first one that I can recall that focused really on the IM sub internship. And it's really kind of a state of affairs in terms of we have an expert panel that's going to be introduced next by Dr. Orr, but I will be doing the introduction for Dr. Andrew Orr, who's one of the panelists, but he's an academic hospitalist at the San Francisco VA. He's an assistant professor at UCSF. And prior to relocating to San Francisco recently over the summer, he obtained his master's in med ed and was an academic hospitalist at the University of Pennsylvania, where he co-directed the IM sub internship there and was really passionate about improving the sub internship at the national level. So Dr. Orr is going to introduce the rest of the panel, and we welcome his presentation today.
Thanks, Brian, and welcome everybody. Our workshop is called Bridging the Gap, the Pivotal Role of the Internal Medicine Sub-Internship in the UME-GME Transition. We do have some content to get through today, and so we'll save time for questions at the end. But during the presentation, please type your questions in the chat as they come up. We'll answer in the chat as we're able to, or discuss in the Q&A afterwards. Our rather large speaker panel today includes sub-I experts from institutions across the country who I have the pleasure of introducing here in something close to the order of speaking. So first, we're lucky to have Dr. Allison Ferris, the Internal Medicine Residency Program Director, Assistant Dean for Faculty Development, and Chair of the Department of Medicine at Florida Atlantic University, as well as a former sub-I director herself. Dr. Adam Garber is the former IM sub-internship director, a sub-I assessment expert, and current director of the acting internship across the entire School of Medicine at Virginia Commonwealth University. Dr. Ersk Anderson is the sub-internship director at the University of Chicago, a current CDIM council member, and a sub-internship curricular innovations expert. Next is Dr. Bob Vu, sub-I director at the University of Indiana, and too modest to say it, but there's a reason we put him in the center square as our resident expert on all things sub-internship and sub-I scholarship related. Dr. Jen Reedlin is the sub-I director for the University of Rochester and also is involved with individualized learning plans and preparing for the transition to residency throughout the fourth year of medical school, among the many other educational hats that she wears. And finally, Dr. Ashok Lingana is the Senior Sub-Internship Director at the University of Pennsylvania, where he is also the Associate Director for Undergraduate Medical Education in Internal Medicine and recipient of countless teaching awards. Here are the learning objectives that you saw in the webinar registration. Our overarching goal today is to shed light on the sub-internship on both the national and local levels and crack open the black box that is the sub-internship outside of your home institution. The last thing I'll say is that we are going to use the term sub-internship and acting internship interchangeably. It just depends on whatever institution we're coming from. But now I'll hand things over to Allison to remind us of the downstream consequences of the sub-internship and why this is such an important rotation.
All right. So as a current program director, I am on the receiving end of the students that come out of the sub-I, and so I want to share with you some literature and some thoughts from what do program directors think about sub-Is. So this was a paper from 2009 in academic medicine that actually did structured interviews of 30 different program directors. And really the PDs came down to identifying common struggles, which included lack of self-reflection, poor organization, professionalism that could be better, weak medical knowledge. And when it came down to it, when they said what recommended rotations would you suggest that students coming into internal medicine take, the sub-I in the chosen field was the clear winner. And you can see that the sub-I in internal medicine, not that we're biased, came in at a 50%, and then IM subspecialties tied with that as well. So, really the PDs were identifying struggles even back, when probably some of us were not far out of our residency training. The next paper is by Steve Angus and colleagues, and actually Bob is on this paper. So again, this was looking at what do new interns need to have when they come in. And so they did a Likert scale. So if anything was rated a 4 or a 5, it's included in this list. And if you look at the top 4 specifically, knowing when to seek assistance, communicating with the nurse, doing time management, communicating in a culturally sensitive manner, and then bringing in information management and prioritization, I will just highlight that those tend to be the things that correspond to the sub-I curriculum, just spoiler alert. But you can see that they were really the clear winners of what PDs are expecting interns to do. So nothing on there says that we expect them to be medical knowledge experts, but really we expect them to be able to communicate well, manage their time, be organized, etc. So moving on, this paper came from work done by a group called Cacti, which was via AAIM, and it was looking at what should the 4th year overall look like, and what is the current state. So at the time, and this was back in the mid 2010s, the sub-I was required in 90% of the schools. And what they did is they actually did a deep dive into the websites of the different LCME accredited schools at the time. So 90% required a sub-I, but it varied by school. So some schools had 4 or more different disciplines that sub-I could be done in. That was 45% of them. 20% required 2 or more. Some schools allowed a choice between 2 or 3 disciplines. Usually that was like medicine, surgery, peds were the ones that were commonly selected. And only 10% at the time required a medicine sub-I. At the time, capstone courses were really sort of, starting to hit their stride. And at that review, 59% of schools had one. And then research and scholarly activity and basic science were certainly the lower level requirements in many of the schools. They asked about specific rotations like emergency medicine. So 45% of schools at the time had an emergency medicine experience that was required, but it could be 3rd or 4th year. 34% required an ICU, 35% required ambulatory, and 75% required neurology, although 3/4 of it was as a 3rd year clerkship rather than 4th year. So again, just looking at what does a 4th year overall look like, and how does that best prepare students for residency training. So then the next is sort of, okay, well, if the program directors think this is what the residents need, what do the residents and interns think that they need? So this was looking at residents and interns, and I believe this was residents taking the in-training exam, and they put these questions at the start of it. So what they said, what were the most important skills that you wish you had or needed to have on day 1 of internship? And you can see, again, when to ask for help, how to prioritize your time, how to communicate with others. Those were the clear winners. And then they said, well, what course was most useful to prep you for your internship? And not surprisingly, the overwhelming winner was the sub-internship. So then there's been a lot of literature more recently, focused specifically on that UME to GME transition. And so, just highlighted 3 different papers here. One is of course, talking about how does the MSPE display and portray the students? And is there a disconnect between what that letter says and what the true abilities are when they come in? And really, this paper was calling for a better handover. Followed up by a paper that a group that I was part of through AIM and led by Amber Pinkavage and John Cho, where we were looking at the individualized learning plans. And this was really meant to be a student-driven tool. So students would be the person filling it out with a faculty advisor or a faculty mentor to help them. But it was really meant to be like a what do you need as a brand new intern coming to my program? And this is an evolving area, and I think we'll probably see more literature about ILPs in the future. And then the last is looking at, is there something that we as AIM or as medical schools could do, to say what standard content should be in a 4th year capstone course and GME? And you can see this paper if you're interested. Just a quick comment about 4th year slide. This was some unpublished data from the NBME where they gave the 4th year sub-I exam to interns about to start residency, and they compared it to fourth year sub-Is actually taking the exam during their fourth year. And you could see the fourth year students actually outperformed the interns, which makes us wonder, like, what the heck happens in the last 6 months of fourth year? And I'll turn it over to Bob.
All right, thanks, Allison. So the current sub-I curriculum 2.0 for internal medicine was released in 2018. And like its predecessor, it was developed based on program directors and resident input by way of survey data. The curricular guide was developed by an AIM level joint committee consisting of both the APDIM and CDIM members. The program directors also directly contributed to this curriculum by being co-authors. And they also served as internal peer reviewers. So, it's been 5 years since this curriculum was released. And so we wanted to know what new innovations out there have been published by our colleagues. So in our review of the literature and AIM presentations, we found the following curricular innovations. I'm not going to go through them all in detail, but I highlighted and read, some of the core topics. And many of these are actually done by my webinar colleagues here. So they're going to go over some of these in much more detail. But as you can see, it's microblogging to augment the semi-clinical learning experience, EPAs, asynchronous learning modules, especially relevant in the age of COVID, time management, EPA 4 on how to enter orders. Next slide. More curricular innovations that talk about discharge curriculum, again, time management, writing orders, assigning sub-Is to resident versus non-resident teams was also quite prevalent over the last few years worth of AIM presentations. Next slide. There were assessment innovations over the last 5 years, assessing EPAs, transitions of care, discharge in particular, and OSCE evaluating communication skills. And then we chose to also review the past 5 years worth of boot camp or capstone or transitions course content as well. Reason is, to use a metaphor that actually fits quite well here, is that, the sub-I should not and cannot serve as a galactic singularity into which more and more content is stuffed, to reach infinity. So, the wealth of knowledge and skills development should be spread to other fourth year courses, and the most closely related of which to the sub-I in terms of internship readiness training, is the bootcamp or capstone innovations course. And as you can see here through the highlights, a lot of it is about first call page training to deal with triage skills and managing overnight calls and cross coverage. There's a curriculum on EMR training and discharge summary training as well. And then on the next slide, there are more curricula about same thing, EPA 10, which is cross coverage, triaging skills, patient evaluation skills. There were a couple of them on patient safety and quality and incident reporting. So again, we chose to review only sub-I or AI and bootcamp courses and not others. So we didn't include anything about post-match learner handoff content, such as the ILP that Allison was mentioning. So really, in conclusion, of this limited review of the published literature and AIM presentations was that most of the content mirrors the current sub-I curriculum, with the exception of some patient safety and quality materials. So this sub-I curriculum still seems to be relevant. So now I'll turn this over to Adam, who will present national survey data, both recent, past, and present, to give you a broader landscape of the IM sub-internship.
All right, thanks, Bob. So you can see the last time the CDIM survey addressed the sub-I rotation on their survey was in 2017. You can see by this paper from Dr. Pinkavage and all. So we wanted to clarify a few questions from that survey and also gather additional updated information on our survey, which includes this question here on the right. regarding the sub-I requirement for all students, regardless of specialty, as only 13% of schools at that time required all students to complete an IM sub-I. A couple additional highlights from the survey also included a low number of schools that actually require an overnight call or night float on the sub-I rotation, and close to half do not require a night float at all. So somewhat concerning there. All right. Now, the majority of the clerkship directors that completed the survey were also the sub-internship director. However, we worry that the sub-I directors who are not also clerkship directors may be underrepresented on the survey, which could lead to some inaccuracies if the clerkship director filled out the results on behalf of the sub-I director. A few additional results from the 2017 CDIM survey show that a lot is being asked of sub-I directors, and we wear many hats, right? It's highlighted on this table. Despite the increase in complexity of this role, the majority of sub-I directors have less than 10% or really no protected time. Therefore, in order for the sub-I to reach the next level nationally, we need to continue to advocate for protected time for sub-I directors. All right, now on to the sub-I survey. We recognize gaps in the CDIM sub-I survey from 2017 and also wanted updated information nationally on the acting internship rotation. So we aimed to create focus questions mostly related to the sub-I and propose this to the Survey and Scholarship Committee to be included on this past year's CDIM survey. However, those questions were not accepted, and unbeknownst to us, there were actually two groups working in tandem on very similar questions. So we joined forces, and the rest is history with regards to the sub-I survey. This was approved to be submitted on the CDIM listserv by the Survey and Scholarship Committee, which we really appreciate, as this is not a common occurrence. And we opened the survey in January and closed it in March. A few of the results we'd like to highlight. This is the school size of the participants that responded. We had a response rate of 50%. And the breakdown of these schools by class size is similar to the 2017 CDIM survey results. So hopefully this is indicative of what the landscape is nationally. All right, now as you can see by the pie chart on the left, most schools still require only one sub-I for graduation. A few do require two, and very few require three. And while over 90% of respondents said they do not require an IM sub-I for all students, regardless of specialty, it seems like the majority of schools are still, the majority of students are still electing to take an AI in internal medicine, recognizing the value of that rotation. Now, with regards to the away AI, the majority of respondents said they do not allow an away AI to count towards the AI graduation requirement, but this still leaves about a third of schools that do allow it to count or are unsure, which is concerning. Obviously, given the integrity of that AI experience, another school cannot be confirmed. Now, which AI specialties offer a sub-I in internal medicine? As you can see, there's a wide variety of options now. Many subspecialty services offer the AI rotation, but still the bulk of schools, or looks like all the schools, still offer a Gen Med AI component as well. So this seems to be expanding nationally and also adding additional services as the years pass. All right, and the setting. So as with prior surveys, majority of the IM sub-I rotations are entirely inpatient. Very few have an equal mix of inpatient and outpatient. Next, click there. And then the structure. So the majority of the schools still integrate the AIs onto teaching services, which has been traditionally, but I'd like to highlight there that over 40% now offered on hospitalist services, which seems to be a growing trend nationally. Now, when asked about whether an optional or required night component to the AI was offered, only 1/3 of schools responded that they do offer that for the AI. But more concerning, I think, is the 2/3 of schools that do not offer it, or it varies by AI rotation or setting, or site that they offer the AI. Now, of the 1/3 of schools there that do offer the night float or overnight component, only 24% of them actually require it, as opposed to offering as an optional experience. All right, so we wanted to also highlight this given the buzz on the CDIM sub-I listserv regarding who offers nights and what the trends are nationally. But you can see the bullets on the left are from all the CDIM surveys that asked this question over the past almost 20 years now. And you can see that trend is decreasing each survey as you start from the bottom and move up to the top. Now, there were some differences in how the question was asked, but it does seem like this is a trend overall. But our data did suggest this number increased this year, which is promising, but there's obviously still room for improvement. And now next, the intimidating spider plot on the right is from the 2014 JGIM article from Gorin et al. That asked the clerkship directors the perceived importance of each of these activities during the night float to the students. So which one of these are most valuable that they will gain on the night float rotation? You can see the core clerkships in blue, but the sub-I is in red. And as you can see, taking cross coverage and encountering patient emergencies are rated as the highest importance on a 5-point Likert scale, with 0 being in the center and 5 being on the outside of that plot. And then this feeds into gaining experience with future roles. That's another top reason the sub-I is doing this, or having this experience at night during their rotation. Now, however, based on our survey, not only is night float required by few respondents, but only 44% that they allow students to provide cross coverage on their AI. This is concerning, as it obviously handicaps our students and their learning opportunities, experiences they may receive in preparation for intern year. And as Allison highlighted, these are a lot of the top skills that the PDs desire of interns on day one. So while there's a trend that the night float requirement and ability to provide cross coverage seems to be improving overall, there's still a lot of room for improvement here and preparing our students for intern year. I'll turn it over to Ersk and Jen.
All right, thank you, Adam. We skipped right a second. Now Jen and I are going to talk a little bit about our experiences with our sub-internship. So I found out from Jen talking to her the other day that we both started as full directors in 2019, which was COVID years, you guys are aware. And before that, I was the co-director for about 14 years. So we thought we'd start with a table just to do some comparisons. So when we look at our two institutions and how many of the fourth year students actually do an internal medicine sub-I, we're pretty well matched around the mid 40% range. Looking at the services that are offered for our sub-Is, we do overlap with hospital medicine, which is becoming more popular, and ICU. However, we kind of veer off from there. We have Gen Med at U of C, cardiology, and over at Rochester, they have oncology and med psych, and we both do have a community affiliate option as well. Looking at how many sub-Is, if we had full capacity any given month, how many sub-Is would that be? For University of Chicago, we're at 8, and for Jen, they're at 11. I'll talk about my call structure. I'll have Jen talk about hers in a couple minutes. We do not have any more 28, 30, 32-hour shifts with overnight for any of our sub-Is anymore. So our call structure tends to be in the every 4th to 5th day call range with some short call options. Aside from our hospital medicine, which is a drip system, they admit around 1 patient daily, Monday through Friday. We like to look at how many students actually complete their sub-I by the end of August. I think this is important, not only to get a recommendation letter from your sub-I faculty attendings, but also to get some of that narrative into your structured evaluative letter. So at U of C, we have about 54% of ours, and Rochester is a little better at 67%. Of note, we can accommodate all of our sub-Is by the end of August, but many choose not to do it in that time frame for various reasons. So we do require nights and cross cover, and they kind of go hand in hand. So I mentioned all of our call is day call, but the students will do somewhere in the order of 5 to 7 nights in a row, either at the beginning or the end of the month. All of our teaching services are with a night float resident, whereas hospital medicine, it's with one of the faculty hospitalists. We do match up on how many patients they can admit on call, which is 3, which I think is pretty standard. And our overall patient cap per sub-I is 6. You'll hear more about this later from Ashok, I believe, but we are a pass-fail grading. These grades are determined strictly by the faculty who work with the students, not the residents, not myself, although I do review the evaluations. and we do not have a grading committee at the University of Chicago. Then I'll have Jen hit on a couple points of this table as well.
Sure. Thanks, Ersk. So just in regards to our call structure, because we have so many different places where our sub-Is go, their call structure can vary to an every other day long call on our oncology service, which mirrors an intern schedule with, short call days for sure. And then an every 3-day call structure on ICU, to an every, one long call day a week and one weekend long call day every other weekend on our hospital medicine service. So it's quite variable. For our night coverage, we've really only allowed our honors students to do that. So we have the students have to qualify for that by getting a high pass or honors on their clerkship. And most of that is just to try to help students with who need more supervision to gain skills on the daytime. But our honor students do 2 weeks of nights and really integrate into our night float team with that. And we do have a grading committee since we have the tiered grading.
All right, so I'm going to talk a little bit more about some of the curriculum development that I've been involved with at the University of Chicago. This is kind of a timeline, kind of lining it up with the sub-I curriculum 1.0 and 2.0. So today I'll talk a little bit about our sub-intern and report, which we started a whole 18 years ago when I first started as a co-director, 2008, which is a sub-I prep course, and then the e-learning. In terms of the sub-I noon report, I think a lot of folks at this point have something probably very similar to this. Back then, I'm not sure it was as popular, but it's 1 hour once a week, usually over the lunch hour. It is required for all the sub-Is who are on that month. We do invite fourth-year students who are doing an internal medicine rotation. It could be a consult. It could be the ER, dermatology, and we also invite visiting students. So one sub-I is assigned per week to bring in a case. We aren't necessarily blinded on purpose, but we don't necessarily review them with a student ahead of time. So we're coming in kind of blind, which is interesting. The students review that case kind of like resident morning report with the faculty moderating, and then the student is expected to bring in a topic review just to wrap up for the final 5 to 10 minutes. For the time remaining, we cover a CDIM cross-cover training problem from the sub-I curriculum as well. In terms of wellness, we don't do anything formal, but at these reports, I do ask them how things are going, any issues, any concerns, things that are going well or not. And I do offer for them to email me for things that might be more sensitive in nature. And what you can tell we're kind of hitting on here are the top 2, I guess, of the 5 sub-I 2.0 core skills, which is recognizing sick versus not sick, and then knowing when to ask for assistance. Now we'll fast forward about 3 years, and it's been a while, so my brain kind of forgets a little bit as to how this all came about, but I know we partnered with our pediatric sub-I director, Dr. Schwab, as well as the medical school, and we came up with this idea of having an all 4th-year sub-internship preparatory course. So historically, this again is a 1-day course. Near the end of 3rd year, all students are excused from their rotations for that day, where we have didactic speakers come in. These are often very dynamic speakers, very interactive given our small class size, and talk usually for 45 to 60 minutes on high-yield topics from the curriculum. So you can see in my animations here, we've got the Lego handover. We have end-of-life discussions. We have informed consent. We have a great lecture that Dr. Farnan does on central lines. And the 2 other ones you see there with all the hands in a circle, that huddle, that's our multidisciplinary team roundtable. So we have a representative from social work, physical therapy, case management, rehab, geriatrics, all come in. And we have, I think, 2 cases typically that we'll run through from patient admission to discharge. And we really try to pick each of their brains as to what they're thinking as we're going through the case. And again, very interactive. Students are allowed to ask questions throughout. It's a very highly rated session. And then the last one there with the clipboard, that's our prioritization and time management. And that is a chief resident roundtable. So we invite 3 to 4 chiefs from the different specialties to come in. They are actually given questions submitted ahead of time by the sub-Is or the about to be sub-Is around, burning questions on how to be the most efficient and effective sub-I or intern. And again, this has been a really highly rated session. I think very informative for the sub-Is as they're about to start. Other topics that we've talked about during the sub-I prep day have been opiate use disorder, high value care, how to call a consult, answering nurse pages, use of an interpreter. We were starting to get the feedback that they wanted more hands-on, so small group learning sessions right before COVID hit, and then COVID hit, kind of blew everything up, educationally. So since COVID, this has been a strictly online course that's elective, so it's not mandatory, but students will get credit. We have 7 to 8 narrated PowerPoint modules that the students can review. They have to review 5 of those, and then feedback to me 3 learning points from each of those 5. We're hoping, as we are in the middle and hopefully getting toward the end of our curriculum rehaul, that we'll see what the next version of this looks like. Next slide. Oh yeah, sorry. So what we're really hitting on here are the bottom 2, managing time with the chief resident roundtable, but very heavily towards the communication with the healthcare teams. And the final curriculum initiative I'll talk about is this e-learning modules. There's a QR code link to a paper that we published in AIM Perspectives. So this idea came out of Johns Hopkins with Dr. Pawa and colleagues, but Dr. Garber was involved in this, as well as the University of Colorado. So a few of the MedPeds residents at Johns Hopkins created these narrated PowerPoint modules that were hosted on YouTube, and they centered around acute inpatient management of heart failure exacerbations, hyperglycemia, venous thromboembolism, COPD exacerbation, and GI bleed. The students were randomized to either view the modules or not on an every other month basis. Students were given 10 item knowledge questions, 2 per topic, both before and after the sub-internship, as well as some questions around just comfort recognizing and treating these 5 conditions. The post-survey included some additional questions around ease of use, overall usefulness, satisfaction. Would they recommend it to a colleague? Would they use it on another rotation, etc.? What we found is that these e-modules did not improve knowledge or comfort around these 5 conditions. And another interesting thing that we discovered is that before the sub-I, around 48% of the students prefer digital or e-learning, to gain knowledge around these different areas, or just knowledge in general around medical conditions that they're going to see in the sub-I. Whereas after the rotation, the majority of the students ranked their own patient or co-intern patient as being the most useful. And finally, just because we've been doing this for a long time as well, the sub-Is are required to do 1 observed handoff to the night float resident. This is observed by a separate resident who is not involved at all otherwise with teaching the sub-Is. But as a senior resident, they observe, score, and then give formative feedback to the sub-I. This does make it into their official file, but it doesn't provide a grade, as again, we are pass-fail. So with that, I'll pass it on to Jen to talk a little bit more about what they're doing at Rochester.
Thanks, Urs. So as Urs mentioned, I became sub-I director in 2019. I had no co-director role before then, but was lucky enough to attend AIM at the time and learn about sub-I curriculum 2.0 and meet some of our wonderful sub-I directors who are here today. So again, focusing on these core skills, I'll kind of go through the timeline of what I've updated in our curriculum and how we apply it. So there was already a first day orientation in place when I joined, and then the last day of the rotation, students took the Aquifer Clinical Decision Making exam. I noticed with that our night float students who were ending didn't perform as well, even though they were our honor students and presumably were performing well. So it seemed more an environmental issue. So after the conversation at AIM, I ended up, or AIM week, I ended up making an academic half day where students take the Aquifer Clinical Decision Making exam as more of a formative assessment, as many of them are coming off a year off, and it's sort of kind of jumpstarting them and remembering all of the medicine that they know or maybe need to refresh on at the start of their rotation. And then as you'll see as we go along, we cover time management skills, as well as just how to use the medical record in writing orders. Then we do a mid-rotation check-in, which previously happened sporadically, not with every student. Now it's standardized to help happen halfway through for every student. And then we end with one of my favorite activities, which is a podcast assignment where students listen to 2 podcasts, and we have a roundtable discussion about their reflections on it. And it's more the psychosocial aspects of medicine, or things that, aren't just a CHF exacerbation, but what do we do about somebody with a CHF exacerbation who wants to be discharged AMA? and kind of talk through that. And the QR code there is the list of podcasts that I share with the students, if you're interested. So the heart and the meat of the rotation is determining if a patient is sick or not sick, and just that clinical experience. So this is what they're getting at the bedside every day. They do attend intern morning report every week. It's not something that I attend, but now I want to based on everybody else's talks about it. So I'm going to work on that. But that's the heart and the meat of the rotation there. When we go through asking for help, I highlight the 2 articles that Allison spoke about regarding what residents and program directors say what skills students should have. And even though the point of the presentation I'm giving is more about the prioritizing tasks and time management, which rank highly there, I also point out that knowing when to ask for help is a skill that they need to have and need to focus on, and not asking for help can actually be detrimental to them and potentially their grade, since that's so motivating at the time if they're too big for their britches. So it's covered in orientation and at that time. And then this is the time management project that we do. So I incorporated right when I started as sub-I director. We didn't have the most robust QI program. Now it's really robust, and the students have greater skills than they did when I first started. So I was combining time management and QI by doing PDSA cycles with the students about their own time management. And we still do this, but in a much more scaled down way. And it's really also helping them with self-reflection and identifying gaps in their skills and also where they succeed. And these are some quotes from the students that just taking the time to focus on their time management and figure out what they needed to do, help them be more efficient, help them give time for other things in their day or things in their lives, and kind of readied them for their intern year. And then in communicating effectively within healthcare teams for that piece of it, it's really, again, a lot of the day-to-day for our students. So all attendings use their notes for billing. So that kind of communication is there, as well as feedback. They call their own consults, they update families, they give their own handoffs. It's observed by a senior, but not necessarily in the same structured way that ERSC does it. And the most important thing, and I think what students value the most, is that they serve as covering provider. So in EPIC, that's what anyone whose first call is designated as. And so nurses contact them when there's an issue. So social work reaches out to them to say the patient has a bed offer. The care coordinator will ask them for DME, and they have to figure out how to do it and to ask for help to make sure that it happens too. So that's where they get a lot of that in the practical way of it. And our 3rd year clerkship students get a little card that they bring into their 4th year on how to call consults as well. That was in the sub-I curriculum. And lastly, for the wellness piece, so I review about halfway through. All students fill out this form, no matter what site they're at or what part of the rotation they're on. And we talk about kind of their goals for the remainder of the sub-I, because they're 2 weeks in at this point. We review any feedback that they've heard. We don't often have evaluations filled out at this point, but they've certainly met with people for feedback. Any concerns about their experience. We review their clinical decision-making exam performance, as well as talk through their PDSA cycles and their time management. But this is also an opportunity. If I'm noticing some burnout in students, I remind them that we do have days built in to their schedules where if they need a day off, they should take a day off, and keeping that wellness in mind. We also will fill out together. We have an event reporting system for any bias, discrimination, or unprofessionalism that they often are hesitant to fill out on their own. But if they bring up an issue with me, I'll often fill it out with them right then and there to kind of show, and then they get feedback on their reporting too. So I think that helps contribute to their wellness, knowing that they're being heard when they express concerns. So those are the different ways we've tackled the core skills in our sub-I at the University of Rochester. And I'll pass it over to Ashok.
I'll actually take it from here. So, we wanted to zero in on the many differences between sub-internships at different institutions, but to close the talk, we'll zoom back out to the one thing that's the same. throughout, and that's the fact that the sub-I is meant to serve as a bridge from the clerkship to the start of internship. Now, in an ideal world with a strong and highly functional bridge, information about our trainees regularly flows freely in both directions. However, one other statistic from the national survey that I wanted to mention is that only 29% of institutions are including their sub-I grade distributions in the MSPE for residency applications. And so that's why our bridge looks a little rickety in terms of that free flow of information. We also know that sub-I expectations and evaluation measures vary widely across institutions. On one of our planning meetings, Allison expressed the frustration that many PDs feel when they just don't have time to read the nitty-gritty of what your sub-internship exactly looks like at your institution when it's so different based on where everybody is. So to fortify this rickety bridge so it adds value to the UME-GME transition, we need to find a way to accurately assess and concisely and transparently communicate meaningful information about students. And that's where competency-based assessment comes in. The AAIMC's UME to GME Review Committee issued a call to improve UME-GME transition that specifically mentions changes in assessment practices. And several of their core recommendations relate to developing a common assessment framework across the UME to GME transition and using robust assessment tools and strategies to do so. Now, at first, this sounds like an unachievable, platonic ideal of assessment, but there are certainly things we can do as sub-I directors to contribute to a shared mental model across the continuum. And on that note, let's talk about the AAIMC's core and trustable professional activities. For competency-based assessment, there's also the AAIM framework and the ACGME milestones. We'll touch on them later, but for right now, we'll focus on the EPAs because these have been gaining traction in the sub-internship nationally. The EPAs also satisfy both of the committee's recommendations from the prior slide. Now, this slide is showing the 13 core EPAs, and what Ashok has highlighted in bold are the actual competencies referred to in each EPA so that we can consolidate them and make them more concise. And great slide work here, Ashok. It just looks a little cleaner like this. And when you lay it out, like we just did, one nice thing you can see is that the EPAs are longitudinal, and so they really help us with that continuum of clerkship, students to intern, and that transition. Some EPAs, like history and physical, documenting, giving an oral presentation, are more applicable in the clerkship. Some, like building a differential diagnosis, overlap with the sub-I. But the higher order EPAs, like patient handover, entering orders, determining sick versus not sick, are almost exclusively practiced during the sub-I. So then the question is, are we using EPAs in the sub-I at all right now? The national survey asked this question too, and the short answer is yes, but the survey broke things down by the specific EPA, and so there's a range. The percentage of institutions incorporating EPAs into assessment ranged from 18.3% for the procedural EPA to 47.9% for the differential diagnosis EPA. So they are there. The next question is, well, how are they being used? Several institutions are using them as the basis for formative workplace-based assessments for sub-Is. For example, shown here is an EPA-based rubric called an entrustability scale that we'll discuss more in a second. Several institutions are using EPAs as part of a sub-I's summative evaluation. For example, the University of North Dakota uses a different entrustability scale to evaluate their sub-Is on 10 EPAs. A few more points about the entrustability scales. Their purpose is, instead of asking an evaluator to rate how good a student is at performing a physical or assessing a sick patient, to ask them how much they trusted a student to do these things competently. It puts the focus within the evaluators themselves to understand their own feelings and willingness to grant trust, which is often easier to do than gauging someone else's abilities. There are two validated scales, the supervisory or Chen scale and the coactivity or Ottawa scale. It's important to talk through some of the differences. The main one is that the supervisory scale projects ahead about how much supervision a student will need moving forward, whereas the coactivity scale relates to how involved the supervisor was in an interaction that already happened. One helpful analogy is that the supervisory scale is like forecasting the storm in the future, whereas the coactivity scale is like tallying rainfall afterwards. And it seems like a small distinction, but certain people are more comfortable doing one versus the other. I'll show you a version of each scale again so this makes sense. And this figure comes from a 2020 head-to-head study that was testing the two scales against each other in the sub-internship. And so the language of the supervisory scale, again, is projecting forward. And so the benchmarks are a little different between the two scales. For the supervisory scale, you can imagine how this might be easier to use for an activity that's safer and lends itself to delayed supervision, but may not require, quote, coactivity in the moment. So something like documenting a clinical encounter. Whereas for the coactivity scale, this might be more applicable for procedures or tasks that do require coactivity in real time, something like signing out patients or evaluating sick patients. Now, importantly, they also included an area for narrative comments. Unfortunately, in that study, neither scale performed particularly well, and there was low variance in scoring that was attributed to the learner. But they did note a few things. Supervisory scales may overestimate experience, whereas coactivity scales may underestimate it. It's also worth noting that neither scale includes an indication of case complexity, which is important because students have to perform the EPA in both simple and complicated circumstances. So we're still gaining more information with each study of entrustability in the sub-I that comes out, and right now we're left grappling with more questions than answers, unfortunately. A lot of limitations here, but basically one option forward might be to use a hybrid approach where we, 1, report how much supervision the trainee needed for a current case, 2, give some indication of case complexity, and then 3, estimate how much supervision the trainee will require for future cases. So there's still a lot of work to be done here to determine the best way to do this, but I'll now hand things over to Ashok to talk about the various ways that our colleagues have begun to synthesize this and put it into practice.
Thanks, Andrew. So, hey, I'm Ashok. I know that my name has now been thrown around a tiny bit, but I've been the sub-I director at Penn for the past 7 years. So I have probably about 5-6 minutes sort of to go over evaluations and sort of how specific evaluations are used at different schools. This is just to say really that we don't have any really specifics on what you should be doing or saying what the best practices are. We're not trying to say this is great or this isn't great. Really what I wanted to do over the next couple of minutes is just sort of give you guys all an idea of different approaches to doing evaluations, as well as sort of assessing the similarities and differences between evaluations, so that hopefully this, it gives you a taste of how other people are doing it. And if you're interested, you can start researching, reach out to us, do whatever it is that you need to do to try and rethink the way that you want to do evaluations. So that's just sort of the first part. So we are 6 schools, so we've split this out into essentially 2 large groups. And so what we have is we have groups that function as honors, high pass, pass, and fail. And we have folks that function as pass, fail. So I had a hard time. It felt like it was really verbose writing honors, high pass, pass, fail over and over again. So I asked ChatGPT to really try and help me elucidate and synthesize this into single words. So I'm now going to call this hierarchical grading or tiered grading and binary grading. So the hierarchical grading is the honors high pass one, and the binary grading would be the pass fail grading. So we're about split 50-50 down the line. I was able to get information from most folks to try and figure out exactly how things compare, but just sort of give you an idea that we're going to talk about both components moving forward. So first, I'm going to start talking about hierarchical grading. So here are the 3 schools that we had discussed about hierarchical grading. What you can see here is that the metrics that they have in common are EPAs. They often also use rhyme-dote, rhyme, or milestones. They have an average of about 5.5-ish to 6 numbers of evaluations that are used on average. And then all 3 have grading committees. Now, I'm going to compare this a bit to the pass-fail system. Pass-fail systems have a lot of different metrics. They use milestones, EPAs, rhyme, and that's sort of how that ties together. Their number of average evaluations is reduced compared to that of the hierarchical grading, where it seems it's about an average about 3 to 4. And then they all do not have grading committees as a standard component of their grading, except for Indiana, which does do that if they're close to fail. Of note, for the pass-fail, there are particular things that are turned in for each student. So admission orders, mini CEX, discharge summaries, et cetera, that are sort of part of the completion, but not factored into their grading, versus when I compared that to the hierarchical grading, there were no sort of completion aspects, and it was all based upon students' clinical skills. So this is sort of what my gestalt is when I was sort of thinking about and analyzing these sorts of things. So I think there's a big difference in perceived stakes of a pass-fail grade versus an honors high pass, pass-fail. One, right, there's clearly like there is a tiering system with one over the other. And two, it is sort of hard to sort of assess how a pass student is who's phenomenal, who's functioning at the level of like a second-year resident is, compared to a pass student who's really just starting to get ready to be an intern, right? So there is this big sort of paradigm for it. So also, I think when we are thinking about how program directors are perceiving pass versus a pass-fail evaluation versus an honors high pass, pass-fail evaluation, there is a higher weight put to an honors grade than there would be to a pass grade. So the stakes for these tiered hierarchical grades are higher. So it doesn't surprise me in this case that there are a higher number of evaluations and there are grading committees being used on average in these situations. Having a higher number of evaluations and grading committees allows you to get more pieces of data, as well as help remove any potential bias that may be affecting people's grades. The other thing that I thought was interesting is the metrics that were used. EPAs were used pretty regularly throughout all of the systems, but RIME really makes a really big push throughout pretty much everything, probably because it's a really well-known and understood aspect of medical education for many years, as well as milestones, but we can talk about that in a minute. Sorry, I realize I'm running behind. So we're going to talk about particular institutional details, and I'm going to be flying through some of these. So I'm going to start out with Penn. So I'm doing Penn because this is what I know best, because Andrew and I spent like about 3 or 4 years really changing everything. So our evaluation structure is using a Likert scale, using modified Ottawa, and using that for EPAs. We then have qualitative statements that attendings and residents can give, as well as formative questions that just give feedback to the students that they can grow from, which are not part of the grade. We do not see that as part of the grading committee. As I mentioned, it's a hierarchical grading system. We have a grading committee. We all do independent evaluations of each member of the grading committee takes a look at the evaluations that each student gets. We then independently come up with a grade. We then meet together. We try to build consensus around one grade. If we are unable to, we then get further information and sort of fight it back and forth. We take a look at the Likert and qualitative comments. We also try to take the context of the student's experience into that situation. For example, if there was an obvious source of bias from an attending or resident or a negative learning environment, we try to take that into context. We also have formative feedbacks. So it's really sectioned out on what we call RIME DOTE, which I'll go over in a brief moment. Just so you know, there are 4 main sub-Is that are done at Penn: EM, FM, PEDS, and IM. EM has their own grading structure. So FM, PEDS, and Andrew and I, we worked together with their sub-I directors, and we came up with a form and a structure that is now used across all of them so that we can all try to have closer semblance of regular normalcy. So this is what we use. We use a modified Ottawa scale. These clearly aren't all of the EPAs. These are just a handful of it. So here's oral presentation, patient handover, recognizing urgent versus emergent care. We walked them through it, directed them from time to time, be available just in case, entrusted the student as I would a junior resident. The idea is not that they would all be junior residents, but if there is a phenomenal person, we should know. We did not use in-between anchors. We wanted people to sort of choose what they did for their Likert scales. We also gave specific descriptors of each thing and what that would look like. We also have this area for formative feedback. This is where we ask the evaluators how they're doing as reporters, interpreters, doers, triagers, executors, and educators, and talk about if there's focused room for growth, minimal room for growth, and ready for intern year. Again, this does not get released to the grading committee at all. This is strictly used for formative feedback so that the students know what they can focus on and work on to get ready for residency. RIME DOTE is sort of a structure that we use at Penn. It stands for reporter, interpreter. Manager is where we talk about the DOTE. That's where we break things down into doers, triagers, and executors. Doers are people who can do tasks in sort of like a straightforward manner. They may need to be told what to do, but they can do them in a time-specific and hierarched manner. A triager is someone who can tell sick versus not sick. An executor is someone who is able to sort of hear information, pivot on the fly. If they hear that someone is sick, they go there, they're able to start doing a lot of their basic sort of management and process, and then come back and sort of this really high level of functioning of managers. Qualitative comments, we have strengths and improvement. We'll move past this. So we have a grading rubric. So our grading rubric, this is the basic idea between honors, high pass, pass, and fail is based upon the basic ideas from Chen. So you go ahead, I'll double check key findings as honors, et cetera, et cetera. This is a busy slide, I understand. We're gonna go to the next slide. This is an even more detailed idea of what it means to be pass, high pass, or honors for the internal medicine sub-I, although this is shared throughout family medicine and pediatrics at Penn. Again, this rubric is used to try and help us make sure that we are giving folks the grades that we feel that they deserved and that everyone is sort of on the same page about this. This medical decision makes just one of many, many components. Virginia Commonwealth, Andrew, I think, showed this a bit earlier. This is another entrustment scale showing how people can be evaluated and graded based upon the EPAs that are noted around the left side. Go to the next slide. Rochester, this is a milestone base, but also has this rubric based upon below pass, pass, high pass, and honors. These are not here for you guys to read. It's just so that you can reference later on if it interests you, but showing again that there's multiple different ways of doing this and approaching this. Next thing I'm going to be talking about is pass-fail, and Ersk really should be giving this instead of me, but here I am. So the big two components that Ersk used for this, for University of Chicago, is the RIME and ACGME milestones 1.0. Those are really used to try and help come up with the final evaluation. They also have milestone 2.0 based upon the SEL competencies. Here is an example of the way that U of Chicago handles their Likert scale. This is essentially milestone based, where 3 sort of is like you're meeting expectations, 2 is sort of focused room for growth. They also have narrative comments for strength and areas for improvement. This milestone 2.0, not included in the final grade, and U of Chicago is just really starting to study this now to see how they want to use this, both with attendings in residence and thinking about how they want to apply this to their Department of Medicine letter. But these are questions that are based upon the standardized letter that CDIM was suggesting later, or in the past. Final grade, each attending evaluates the student and gives them a final grade. The sub-I director then reviews them for consistency. Of note, just going to go back a slide. Of note, this blank slide is here just for me to remind myself that the pass-fail sort of rubric for this is a bit more gestalty than it was for the like the really hardcore sort of grades that we had for our tiered system at Penn. Again, just a comparison, pass-fail is a very different grading system than the hierarchical grading systems. This is EPMO. This is just an example from Miami. They also use essentially a modified Chen modality to try to talk about how good a student is doing. The things in the red are you're not doing so great. Yellow is you're on your way. Green is you're looking good. And then blue is well beyond where you would expect them for competency. They also base this upon RIME and core competency EPAs. Aggregate grading. So we're going to go to the next slide. So evaluation breaks down. So this is just a sense, again, so that you get a sense of sort of what the giant comparison of how grades are distributed throughout different schools. So I completely anonymize things in order to try and help make sure that there are no issues from any schools in case they wanted to intentionally keep any of the grades hidden. So the pass-fail rates are 100% pass in 2 of the 3 schools that I was able to get information from. There was a handful of people who failed in pediatrics, but that was really secondary to the fact that they stopped showing up to the rotation more than any sort of skills or evaluations that was going on. The next one is hierarchical grading breakdown. I did get some new information last night and didn't have time to update this slide. So for school A and B, oh shoot, sorry, my legend is messed up there, but there is a higher range of honors and high pass variability. So the newest school that I got the information from had an honors rate of 98%. There's also honors rates of 91% and 80%. So then that leads to high pass rates between 2%, 9%, and 18%. And one of the schools even had a fail or pass rate of about 2%. So you can see that the tiered gradings is highly variable across different schools.
I'll close it out and just say that we may not have time for questions, but we are all willing to talk via email on this. But to recap, we've gone through the current state of the sub-I through the lens of program director, scholarship, and logistics. We've honed in on 2 academic institutions to see the flexibility of the rotation at different places. And we discussed EPAs in the sub-I, demonstrating how they may or may not factor into an institution's grading schema. Where do we go from here? Well, as you can see with the drastic expansion in sub-I scholarship that Bob detailed, the critical position of the rotation within the UME-GME transition, and the increasing complexity of the roles of sub-I directors, the sub-I is no longer just an offshoot of the clerkship. So a key next step will be to strengthen the community of sub-I directors, facilitate connections and conversations that increase the transparency of the rotation across institutions. Keep your eyes peeled for the official results of the national survey to be published soon. That can become a starting point for future dialogue. One other goal for the sub-I is to move towards a common assessment framework across institutions so that we can convey meaningful information about our students to both relevant stakeholders and to the students to help them grow. Now, these are lofty goals. As you saw from Adam's slide, we'll need to increase support for sub-I directors to actually have time to advance this agenda. And similarly, we hope to increase the sub-I presence within CDIM with questions on the national surveys, sub-I director representation, and possibly even a separate sub-I directors group. Erskine and Ahmed on council have done a great job advocating for the sub-I. We look forward to working together to bring this to fruition. All of the recorded slides will be available online. Again, feel free to reach out to us. Thank you so much for listening. We'll leave it open for Q&A if anyone has the time.